We are very happy to see you. I'm sorry that our presentation was moved for today and it wasn't possible to do it yesterday. And I'm very happy to introduce you my great friend and a great Italian surgeon, Rossana Berta. She's a specialist in bariatric and abdominal wall surgery. She is one from the expert and professors, inviting professors for a different school that are present in Italy. And currently she works at Policlinico San Donato. It's a scientific clinical institution, a huge group, the biggest private and public group in Italy. And welcome, Rossana, to give your fantastic presentation for our participants. Thank you.
Thank you, Alina, for this invitation. I'm very proud to be your friend, and I'm grateful towards this invitation and towards all your group and all of you. And I think I'm not so great surgeon, as Alina said. I work and I try to do the best for ventral hernia patient. And my topic is very huge. I shared my presentation, and I think that my topic is very huge, and I think that will be limited to ventral hernia, because if I talk about inguinal and femoral, I think that we will finish at tomorrow morning at 8 a.m. And so I think that I talk about only ventral and ventral hernia. 1/4 of all individuals are either born with or will develop a ventral hernia in their lifetimes. And an estimated 400,000 ventral hernia repairs and 300 ventral hernia repairs are performed annually in the United States and Europe, respectively. And a lot of money are spent curing and treating this pathology. Okay. Now I am. And primary ventral hernia are abdominal wall fascial defects not associated with any prior incision or surgery. This is the European Hernia Society classification, and include common defects such umbilical hernias or epigastric hernias, and rare defects like spigelian or lumbar hernia, and can be classified in small, less than 2 centimeters, medium, and large. The recurrence rate of primary ventral hernia repair is between 5 and 10% at 2 years. Oh. I'm not able to go ahead. I'm sorry.
Maybe try to start it again, to close it and start again.
No, and the problem is to I have not the control of the. Okay. Incisional ventral hernia can develop anywhere in the abdominal wall, and where an incision has been made, but most commonly occur at the midline, given that midline incisions are most commonly used during laparotomy. This is the classification of the European Hernia Society, and the recurrence rate of ventral hernia and incisional hernia repair can be as high as 25 and 43%. Is really as not a real good result at the long term, and can be classified on the basis of the site in M1, 2, 3, and 4, and 5, the midline side hernia and lateral side, and are classified in the basis of the width. and there are WE1 when the hernia is less than 4 centimeters, WE2 when the hernia is between 4 and 10, and the complex hernia are the hernia more than 10 centimeters. And the surgical management of ventral hernia depends on whether, depends on the site of the hernia, if it is primary or incisional, depends on the width, the surgeon preference, and the resources available. Not all of us have a robot or some kind of materials that are really, really expensive. It's very important classificate the hernia and in order to choose the best treatment. And the surgical approach must be made on the basis of the fact that the hernia is primary or incisional, and on the basis on the diameter of the hernia. If we have a primary hernia with less than 1 centimeter, this hernia can be closed only with suture and repaired with suture. The suture can be unabsorbable or slowly absorbable suture. But sometimes we need to use the mesh, and it's better use the mesh when the abdominal wall is thin, like in diastasis. Otherwise, we can have a recurrence. The recurrence rate when you perform a direct closure of this hernia is only 1.8% at almost 5 years. When you have an incisional ventral hernia with a width less than 1 centimeter, you must perform a mesh repair, and this hernia usually occurs on a trocar side of a previous laparoscopy surgery, and it's better to repair with mesh, a mesh reinforcement, because we think that this incisional hernia implies failed or poor healing at a previous incision, and a suture repair alone of such hernias will likely result in a recurrent hernia. And the recurrence rate is about 7% at 5 years. Is really higher than the primary. Ventral hernias between 1 and 10 centimeter requires mesh reinforcement for the repair. But the proper approach, surgical approach, open, minimally invasive, either laparoscopic or robotic, and choice of hernia mesh, material and location vary according to the patient and the characteristic of the patient, the hernia, the surgeon preference, and availability of technologies and material. When you have to manage large ventral hernias more than 10 centimeters in width, you have a complex hernia. And when you have viscera outside the abdomen, like this loss of domain, you need a lot of knowledge and a lot of technology to repair this kind of hernia. And you need to know a lot of technique, and these are hernia for very specialized center. About the technique, until prior to 1993, all the ventral hernias were repaired exclusively through open approaches with the Reeve-Stoppa techniques or Chevreuse technique. And Reeve-Stoppa technique was the gold standard for ventral hernia repair until 1993. But in 1993, Leblanc published his first work on laparoscopic incisional ventral hernioplasty. And from these years, laparoscopy started to be used in all kinds of hernias. In the same year, in 1993, Ramirez published his description of anterior component separation, a kind of technique used for repair large complex midline abdominal wall defect that had the advantage of restoring abdominal wall function. With this technique, the anterior abdominal wall is divided and lateral oblique muscles are divided in manner that allows advancement of the rectus abdominis muscles, closing a gap of all more than centimeter. And with this technique, Ramirez demonstrated that a defect of more than 15 or 10 centimeter of the midline can be closed without tension. The revolution and until 10 years ago, we have only this kind of technique, Reeve-Stoppa, laparoscopy, and anterior component separation. A revolution started in abdominal wall repair in 2012, when was described transversus abdominal release by Nowinski and the group of Cleveland, and they demonstrate that it's possible close very large defect, releasing the transversus abdominal muscle, is this another component, posterior separation, and the linea alba can be reconstructed, developing a large retromuscular space for the mesh placement. And the advantage of this technique respect the anterior component separation is that all the skin dissection is avoided, and all the complication of the surgical site occurrences are really less than the anterior component separation. And starting from this this time, a new trend has begun in the abdominal wall reconstruction, and the technical goals that the surgeon must obtain in abdominal wall repair is primary defect closure, must minimize penetrating mesh fixation without compromising the hernia repair. So with a posterior component separation and positioning the mesh outside the abdominal wall. Sorry?
Как вы обычно в таком институте?
Is there any problem?
No,
Can you
everything's good. Do you have any questions? I think we can continue.
Okay. The new trends are that we need to obtain the midline reconstruction of the abdominal wall. Mesh must be implanted in the abdominal cavity. And the solution. These two trends are the technical technique like the reef stopa and the transversus abdominal relief with the peritoneal mesh position. And the laparoscopic IPON is banned from the use of the surgeon and use of intraperitoneal onlay mesh is banned for the surgical community. Because the potential complication of the mesh near the bowel. But this kind of position is due to the fact that is not the problem of the mesh near the bowel, because the mesh are really manufactured for the position near the bowel with an anti-adherential sheet. But the problem is how the surgeon use the mesh, because the mesh is, if you have during laparoscopy, the abdominal wall is about a dome, and if you try to put a flat mesh like a paper, cooking paper, in a dome plate, you see that you create a lot of folds. And if you put a mesh with a lot of folds, you can expect a lot of adhesions and subsequent complication. So the problem of laparoscopy, I think, is not the mesh, is how the surgeon use the mesh and fix the mesh inside the abdominal wall. If you are able to use the mesh really flat, I think that laparoscopy is a good technique and works very, very well. And to perform a correct IPOM, laparoscopic IPOM technique, the trend is that you must close the defect. If the defect is less than 5 centimeters, you must use an adequate overlap. Must be more. It must be 4 times larger than the diameter of the defect. So if you have a defect of 2 centimeters, the diameter of your mesh must be 8. If you have a patient with a lot of visceral obesity, you must use permanent fixation. Otherwise, the pressure inside the abdominal cavity can push your mesh inside the defect, and you can have a new bulge and recurrences. And if you use your mesh in a flat position without shrinks, you will have a good repair. And the mesh must be strong, biocompatible, and you need to avoid light and ultralight mesh overall in obese patient. Otherwise, the mesh can be fractured under the pressure of the abdominal wall. And these are examples made with Alina of laparoscopic IPON in obese patient, diabetic, and with COPD. And who was a patient with a lot of problem and was an hernia of 9 centimeters, and we prefer to only in order to avoid infection of the wound infection, to perform laparoscopic approach in this patient. If you have a thin patient, it's better to perform probably in this kind of hernia and sorry, an open approach. But anyway, after 3 years, this patient stayed very well, and he has no bulging. And despite all the statement of the society, IPOM is safe. These are the Italian guidelines. Sorry, on laparoscopic ventral hernia repair for hernia around less than centimeters. And data demonstrates, and evidence is that laparoscopic repair in ventral hernia has less infection, less morbidity, less length of stay and pain, recurrence, time of operation of open approach, and has the same quality of life. So this trend of avoid laparoscopic technique, I think that has not a great justification. And for this reason, the surgical community state that is better to use new extraperitoneal technique, not open but mini-invasive. And so many surgeons and Igor Beliansky and Victor Radu in Europe developed new technique in order to repair minimally invasive repair of ventral hernia, positioning the mesh in retroperitoneal position and perform, and they demonstrate that it's possible to perform a reeve stoppa technique and even a posterior component separation in minimally invasive, using a minimally invasive technique, laparoscopic. But I think that this technique is very difficult to perform and requires really a long learning curve. Can be used only in smaller hernia, less than 8 centimeters, and has no control on adherence. And in incisional hernia, it's possible to damage the bowel because you have not the control on the hernia inside the hernia sac, and it is really time consuming. But is a really anatomic and nice technique. And many studies demonstrate that this is a good technique, but there is no statistically significant difference between intraperitoneal versus extraperitoneal mesh positioning. So is equivalent to laparoscopic IPOM in terms of surgical site occurrences and readmission and recurrences. And the new trend in hernia repair is the robotic repair. The robot has opened a new door and addresses several limitations of laparoscopic surgery with his degree of movement With the robot, we can perform really complex hernia. The robot facilitates a minimally invasive ventral hernia intervention that require the surgeon to work on the ceiling. Most of the operation are made suturing the mesh to the abdominal wall in the iPhone position. But recently, the robot has used to perform the rivstop technique or the transversus abdominal release. The transversus abdominal release is the really best, the robot is the best tool to perform the transversus abdominal release. You can close defect greater than 14 centimeters wide. But you have no control on the sac, on the sac of hernia if it's huge, and it's difficult to perform if you have large pieces of mesh when you perform reduced surgery in abdominal wall. And when you perform the robotic TAR, you are not able to remove all the skin if you perform all the operation with the robot. Otherwise, you can use the robot with the hybrid combination. So you can isolate all the abdominal wall and the muscles with the robot, and then you can perform an incision and remove the sac and close the midline with the open access. And the robotic TAR is difficult to perform in very slim patient. You have not the space to use all the arms of the robot inside the abdominal wall. And it's difficult to use in combined median and lateral hernia gaps. And it's difficult when you have loss of domain, when you have the skin attached completely to the bowel, like in an open abdomen. And again, if you look at the literature and the evidence, you can see in this really huge database of the Vizient clinical database on around 50,000 patients. You can see that the robotic approach, the robotic ventral hernia repair, is not superior to the laparoscopic and open one. And in terms of mortality, readmission, postoperative infection, and is really expensive and time consuming. But I love the robotic technique. And I think despite this result that it is the future, and with the robot you can develop a new technique. With the robot you can instead of isolate. I'm not able to start this video, but in this video can demonstrate that you can repair the abdominal wall only through the isolation of the peritoneal sheath without disrupting the posterior rectal sheath. And you can close the abdominal wall. You can see in this picture of this patient. He had an incision for the prostatic resection, robotic resection. He had a hernia, a median hernia, subumbilical hernia, and I repaired pre-peritoneal with the robot and see the result after the operation. And you can perform a huge posterior component separation without isolation of the posterior fascia. So you can perform a pre-peritoneal separation using the robot, and I think that will be really it will be the future, but you can perform this only using the robotic technology. And the transversus abdominal release has really bad complication. If you don't perform this, if you perform this technique in a bad way, you can have disruption, denervation of the abdominal wall, disruption of the midline, of the semilunar line, and really you have a great damage of the abdominal wall, starting from a small hernia. And in USA, there is a great debate on the use of robotic surgery in abdominal wall, because the results are really bad. And for small hernia, lot of surgeons started to perform TAR with really bad result. And if you try to repair a complication of transversus abdominal release, you can expect a lot of wound complication, reintervention, and a lot of recurrences. And so this the transversus abdominal release, either open or robotic, must be done properly and in the right way. Otherwise, it can be really a disaster. And regards the technical techniques that the surgeon must use, Danish surgeon created this algorithm that is published in their site, in the Dansk hernia database. They demonstrate from the large database that all the hernia with a width of 10 centimeter can be performed, the repair can be performed by all the general surgeon. But if you have complex hernias, parastomal hernias, or with infection or loss of domain, this hernia must be treated in a center, in very large center specialized in abdominal wall repair. And if you have a complex hernia with a loss of domain, so this is really a challenge. And most of the time, these complex hernia are in obese patients. So this is my passion, as Alina knows. And this hernia are really complex. Only a few surgeons are able to try to treat this kind of hernia. And the first problem is how to do in this patient. And the first step is to analyze the hernia characteristics. So the surgeon must evaluate if the patient has a loss of domain, more than 25% of the volume of bowel outside abdominal cavity. What kind of previous repair has been done in patient, if a stoma is present, if infection is present, if the hernia is recurrent, if the mesh is infected, if there is a lot of skin to manage. And you must evaluate very well the patient with the comorbidity. If you have a small hernia like this patient, you must evaluate BMI, if is present diabetes, and if diabetes is compensated or not, if the nutritional status of the patient, if the patient has respiratory problem or malignancies, anticoagulative medication, or if is assumed immunosuppressive medication. And so you can have a small hernia in a complex patient, so the hernia becomes really complex. Is very, very important the optimization of the patient before the repair. So now the surgeon must use all the tools available to optimize the patient before the operation. And today we can use the Botox, not for the wrinkles, but to relax the abdominal, the muscles of lateral muscles of the abdominal wall in order to reduce the tension of the abdominal wall. You can use bariatric surgery for the weight loss or the new molecules, new hormones in order to reduce the weight of the problem, the weight of the patient.
Previously, in order to close
and you can use the progressive pneumoperitoneum, and after the optimization, you can decide if you can operate the patient with a mini-invasive technique, the robot or laparoscopic technique, or you need an open component separation.
Previously, in order to close complex hernias, time-consuming abdominal wall reconstruction procedures were required. Fasciotense hernia makes it possible to stretch the abdominal wall
a new revolution
in approximately 30 minutes via standardized controlled traction. Thanks to the CE certified fasciotense hernia, a mean gain in length of approximately 10 centimeters.
And this is a new revolution that is developed in Germany. It was an intuition of my friend. His name is Jerome Lil. He is an emergency surgeon, and he developed the system of fascial traction in order to avoid the retraction of the fascia of the abdominal wall in open abdomen. When you perform an open abdomen in emergency, if you have really a high pressure, intra-abdominal pressure, you cannot close the abdomen until the pressure is enough flow. And the problem for emergency surgeon is to close the abdominal wall after the critical period is finished. And in order to avoid the retraction of the fascia, when he performed the open abdomen, he started at the first time, the first minute, to put a lot of stitches on the border of the fascia, and he put with this kind of instrument, this is something kind of torture, instrument of torture, to maintain the length of the fascia intact. And after 6 or 7 years, he started to apply this kind of technique to the ventral hernia. And he thought that the retracted fascia or ventral hernia can be elongated with the same mechanism. And the results that he demonstrated are really interesting. And a few papers are present in literature on this technique, and you can see that you can isolate only the rectal muscles, and you can perform only a reeve stoppa technique, and then you can apply to the medial edge, on the medial edge of the rectal muscle, so the fascia of the rectal muscle. This only a lot of stitches, 6 or 7 stitches per part, on each side of the rectal muscles, and you can perform a traction and vertical traction, and you can close completely an abdominal wall, a defect of more than 10 centimeters. In some cases, can be obtained a complete closure of 20 centimeters hernia without using component separation. In this technique, you must apply it with special instrument around 15 kilograms on the abdominal wall, traction for 30 minutes. And this stretching of the abdominal wall, so seems a contradiction. You use a stretch in a tension-free technique. All the tension, all the abdominal wall repair must be tension-free. And with this technique, you apply really a great tension on the abdominal wall, but in order to elongate it. And then you can close without any dissection of the abdominal wall, and sparing a lot of time and all the structures of the abdominal wall. Oh, I cannot, this kind of technique can be used during laparoscopic and either robotic operation. So I'm so sorry, but I don't know why I cannot start all this video. And the result of this technique published recently is that can be completely closed. The direct closure rate is 90% in defect of 10 centimeters, and even in women with a defect either of 20 centimeters is really possible to close the midline. In males is less simple because they have muscles really straight. And in this paper of fascial tense is demonstrated that the surgical site occurrences are less than the component separation, posterior component separation, and the recurrences are very low after 5 years. So it's really interesting. In conclusion, I think that today IPOM still plays a role in abdominal wall repair, in obese patients, and in older patients. Extraperitoneal mini-invasive technique and elongation fascial technique still require data to prove that offer advantages over laparoscopic IPOM and open. I think that robotic surgery is the future, but the platform in the market are really bulky and overall expensive. And furthermore, there is a lack of evidence that is advantageous, especially in complex hernia. But the most important thing is the choice of mesh, location of the mesh, technical surgery, and all the choice on the patient should be based on the current evidence, surgeon and center experience, as well as individualized to each patient. Thank you. I'm so sorry about the video.
Thank you very much for your presentation, and now it's time for the questions. Please feel free to ask all the questions, and we start with Bogdan Mikhailuk.
Thank you for the lecture. I want to ask you about fixation in TAPP and TEP during inguinal hernia repair. Do you use any fixation?
Yes, I perform TPP and fixation only glue and fixation with stitches when I have a hernia more than 3 centimeters. Direct.
Where do you position these stitches?
I position the stitching on the muscles in the upper part of the abdominal wall. If you have a small direct hernia of 2 centimeters, you can close and make a direct suture closing the defect. If you are able to do it with V-lock, if you have it, or with reabsorbable suture. Otherwise, you can put the stitches on the upper edge of the muscles, avoiding epigastric vessels. And you can use and you can stitch it on the pubis, but the bone is really strong, and so it's very difficult.
Thank you very much.
You're welcome.
Thank you. Please, Alexander Boy.
Thank you very much for your lecture. I have 2 questions. Maybe the first one is very simple. What advice could you give to prevent hernia in the trocar placement? And the second, could you give any advice on the management of patients with hernia after frozen abdomen?
After a frozen abdomen, wow. About the trocar hernia, I think that you need to close only midline incision in laparoscopy, because if you insert your trocar when you perform a pneumoperitoneum with a Verres needle, all the muscles, lateral muscles, are in a different position when you desufflate. So the sliding of the muscles when you desufflate the abdomen close your incision in the lateral incision of the trocar. And in the midline, you must close with the reabsorbable suture, because if you put a trocar in the midline, you must close it. And with a suture pass rather than if you have an obese patient, but it's really important to close the midline suture. And there are a lot of literature on this. And the frozen abdomen is really a challenge. If you have a hernia, I think that the best will be the fasciotense is a new tool. You need only to isolate the posterior rectal sheath, and you can perform a traction on the anterior part of the abdominal wall. And if you put stitches only on the surface of the rectal muscles and the anterior fascia, and then you are able to really perform a traction of the abdominal wall, avoiding the need of adhesiolysis and the need to enter into the bowel. And so I think that, but the fasciotense is a really expensive tool, but avoid a lot of complication, and I think that can be really worst to manage after. If you open a bowel in a frozen abdomen, then the repair really can be really a problem. And they develop this kind of technique in frozen abdomen after the open abdomen. If you wait almost a week, you are not able to close an open abdomen after a week, you can expect a frozen abdomen. And they developed this kind of tool to close a frozen abdomen, and they are able to close an open abdomen frozen either after 50 days. And so I think that this is the best way to manage frozen abdomen.
Thank you.
Otherwise, you can perform a mesh traction.
Thank you. Markian Nosrin, please.
Thank you for the great lecture. I also have two questions. The first one, if we are talking about the patient with high risk for hernia, what do you think about prophylactic usage of mesh, absorbable or non-absorbable one?
I think that the non-absorbable mesh is the best choice. There are a lot of data in literature, and but the results are not really clear. The best technique is to use a mesh in onlay position. So you need to close with small bite stitches and use 3 centimeters for each side of your closure on the midline. And you must close in this way with small stitches first, and then you can use glue or reabsorbable stitches with a non-reabsorbable mesh, polypropylene, polyester, and this is the best. The best results are with this kind of technique. And think that in selected patient must be used in this way. But the most important thing in all the patient is to use the small stitches, small bite techniques, small bite technique. And in obese patient, I think is very important. In patient after liver transplant, after transplantation is important to use. And in patient with immunosuppression drugs is important. But there are more risk of infection and surgical site occurrences, more seroma and a little bit of infection. And do you have any rehabilitation program for the hernia patients in your hospital? Yes, I have a rehabilitation program for obese patient. In patient with a BMI more than 30, between 30 and 35, and more than 35, I perform bariatric surgery if they are not able to lose weight. And if they have diabetes, I perform bariatric surgery to have control of diabetes too. And I try to use a progressive pneumoperitoneum, but now it's for me impossible because you need to have the patient into the hospital for almost 10 days to perform the progressive pneumoperitoneum, so it's really very expensive. And you can have a complication too with the pneumoperitoneum. And I try to use botulinum toxin A, but in Italy is not included in indication for the use, and you cannot use is off-label now. And so not all the hospital are able to give us toxin botulinum because we need a lot of paper and request to have, and is expensive too for this patient. But I think that you can now there are new drugs, new analogs of GLP-1, because all the complex hernia are in obese patient, and you can control if you have no indication for bariatric surgery because the patient is too old. You can use this drug, but they are really, really expensive, and so this is a limitation. But I think that in the future this is will be the way to treat this patient.
Thank you.
And I think that you must have a rehabilitation, respiratory rehabilitation after the operation, because this patient after the repair need to breathe in different way and use different muscles, diaphragm, intercostal muscles, and muscles they are not able to use, they don't use from many years. So they need rehabilitation after this kind of repair.
And also maybe could you tell Rosanna about the rehabilitation really, because in one patient, do you remember that were done MRI that showed that patient doesn't use the abdominal wall for respiratory? Do you remember? And
I remember very well.
Could you please talk this case, because I think it's very interesting how to reteach the.
Yes, and the first step is that the patient is like a singer, and the singer when sing when breath introduce a lot of air into the lungs and push the diaphragm down, and must be able to expand the abdominal cavity and then to contract it. And so a singer is able to use the abdominal wall in order to have really a great breath to sing. And this patient all these patients are not able to use the diaphragm and the abdominal wall to compress the diaphragm. So they have the two problems, the use of the diaphragm and the abdominal wall. When you restore the abdominal wall, they are not able to use either the diaphragm, either the abdominal wall. And the first is to give them, I don't know what's the name of the tool with the three balls that you have to aspire the three balls and pull it up with your breath. So I don't know what's the name. Alina, you know what it is?
Three flow, yeah.
Three flow, yes. Is because you can have the saturation of the problem, and you must involve and all the patient must perform this kind of rehabilitation. All the patient after the operation on their table must use, they have on the table this tool and must use it all the day. And a physiotherapist follow them in order to teach them to reuse the abdominal wall and a new way to breathe.
Thank you very much. We have a
Alina,
question from from Sofia Lesecka. Could we? Okay, thank you.
Good evening. Thank you so much for a beautiful lecture. And I want to ask you about inguinal hernias. When you perform it laparoscopically, do you try to place the mesh a little bit medially to prevent the femoral hernia, especially in women?
In women, you must explore the femoral port, femoral hernia. But if it's close, you must you can close with you must close all the site of the hernia of the inguinal site. So you must put a mesh large enough to cover all the site of the inguinal hernia. If you have an indirect hernia, external hernia, you must cover the medial part of the inguinal canal, and so you must cover the femoral hernia. But in if you have a woman, you must, I think that laparoscopy is the best indication in inguinal hernia in women, because if you have inguinal hernia, with the open approach, you cannot explore very well the femoral canal, and you can do it with a laparoscopic approach. And then if you explore this, you must cover with a big mesh.
And to your opinion, best fixation, tacker or self-fixated mesh?
Oh, self-fixating mesh. You have less pain, less. I use the glue tack, the sunacrylate glue. They fix very well all the propylene and the macroporous mesh, and without any really pain. I think that I do not like tacks in TAPP or in TAP. I use fixation with stitches. I prefer stitches when I perform the TAPP if I have big hernia, direct hernia, or big external hernia. But if you use a large mesh and create a proper pocket, I think that you don't need fixation.
Thank you so much.
We also have one question
Right.
from Vladislav Melnik, please. Vladislav, are you here?
Yes, I'm here, but I wrote in comments, have a bad connection, but perhaps you will hear that. On the second slide, you have image where a patient with a very high IBM. In those cases, what do you use? What technique? And do you perform a prone resection at the same time during open operation?
What?
On the second slide.
Second slide, this patient.
Yes, this one.
This patient, the first operation for this patient was bariatric surgery. And then we perform with the plastic surgeon a dermolipectomy, and after the weight loss, obviously, and the dermolipectomy and the closer and the IPOM technique, because the defect was not so big, was about 7 centimeters. But there was outside a lot of momentum, and after the weight loss was really simple to manage this hernia. The most difficult part of the operation was the dermolipectomy of this patient.
Okay, thank you.
Do we have other questions, or everybody out there ask everything what were interesting?
This patient was really difficult in this that you can see in this picture. It was really a huge hernia with all the bowel inside and with a lot of fluids inside. She had almost 5 liters of serum inside the hernia. And first of all, I performed a sleeve gastrectomy in this patient, and then the resection of the sac. And after the weight loss, after 1 year, she had the sleeve at the weight of 120 kilos, 20 kilos. And after 30 kilos of weight loss, I performed a component separation, a transversus abdominal release. and now she's well and she's at home. She's able to walk now. Other patient really, this is a primary hernia, umbilical hernia. That this patient was really a huge patient. This is the hernia after the weight loss. This was this patient was 80 BMI. His weight was he was 260 kilos, and the tall of the was tall 1 meter and 67 was the height of this patient. And after a cerebral gastrectomy, the weight of the patient was 160, so he loses almost 100 kilos. But hernia was really huge, and the diameter of this hernia was 5 centimeters. And inside this hernia, there was a lot of bowel. So I tried to perform this patient laparoscopy, biolaparoscopy. I tried to retract off the bowel into the abdominal cavity, but into this sac there were a lot of adherence, so I opened the sac and with a skin incision, and I put manually all the bowel inside the abdominal cavity. And then I close it with the IPOM. I return in laparoscopy, come back in laparoscopy, and I close the defect with an unresorbable mesh. And I resect all the skin and the sac over the defect. And it was really, he's well too. An hybrid approach, laparoscopic and open. So I have all this kind of operation. I need another 2 hours to see to demonstrate all this kind of monster and operation. Alina knows very well every time. She says
because Rosanna is very famous because she accepts the patient that were refuted from other centers. That's why she called it to all Italy to help with the patients that don't know what to do. That's why thank you very much, Rosanna, for your great presentation. And I think maybe in the future we can also invite our colleagues to visit you and maybe to spend some time here in Italy. And also maybe it can be very, very interesting and very useful. Thank you very much.
Thank you to you, and thank you to all of you for this invitation. It's been a pleasure to participate to this kind of event. Thank you very much.